Hello, my name is Daniel Clark and I am a physical therapist assistant. This is my capstone project for my bachelor's degree from Pima Medical Institute. The title of my presentation is Exercise with and Without Manual Therapy to Improve Pain Levels in Elderly Patients with Osteoarthritis. Thank you for taking time out of your day to view this video and provide your feedback. Do you love your sweet little old grandmother? Does it hurt your heart to see her hobbling around the house because her knees or her hips hurt? Would you like to see your Nana playing canasta with the girls again? A large amount of our Grammies and Pop-Pops, almost 1/4 of them, suffer from high levels of pain caused by osteoarthritis. So, who am I, and what qualifies me to provide you the information contained in this presentation? I am a 2018 graduate of Pima Medical Institute with an Associate of Occupational Science and Physical Therapist Assistant degree. Currently, I have over 1 year experience working in the home healthcare field, primarily treating senior patients. I am a member of the APTA and subscribe to the home health and geriatric sections of the organization. I will have my Bachelor of Occupational Science and Physical Therapist Assistant degree completed at the end of June 2020. So what will be included in this presentation? We'll discuss osteoarthritis and its frequency and how it affects the senior population, balance issues and falls, various types of manual therapy, some different types of joint mobilizations and manipulations. Then we will delve into some evidence-based research with clinical outcomes following manual physical therapy and exercise for hip osteoarthritis, the effectiveness of manual physical therapy and exercise in osteoarthritis of the knee, and a comparison of manual therapy and exercise therapy in osteoarthritis of the hip. I will then summarize everything and ask you to send me any questions or comments you may have following this presentation. Osteoarthritis is a common disease of the joints that primarily occurs in older adults. This condition is characterized by the breakdown of cartilage, which is a tough but flexible tissue that covers the ends of bones at the joints and allows smooth joint movements. One or more parts of the body can be affected, most often the hands, shoulders, spine, knees, or hips. Areas of bone no longer cushioned by cartilage rub against each other and start to break down, causing severe pain and limitations to a person's mobility. Further damage is caused as the body attempts to repair and rebuild these tissues. The immune system, which plays a role in healing injuries, targets these areas, and its response leads to inflammation of the joint tissues. Abnormal growths of bone, called osteophytes, and other tissue can also occur and may be visible as enlarged joints. Osteoarthritis is most common in middle age or late adulthood because the cartilage at the joints naturally begins to thin and wear as people age. However, it can occur earlier in life, especially after injuries affecting the joints, or to those people who are overweight whose activities are particularly stressful to the joints. For the informational purpose of this assignment, I will be focusing on the treatment of elderly patients. Osteoarthritis is a very common condition, affecting about 23% of adults in the United States. In middle age, it affects more women than men, but by about age 70, most people of both sexes have some symptoms of the condition. Severe osteoarthritis is a major contributor to disability worldwide. The prevalence of osteoarthritis has doubled in the United States since the 1940s, and research indicates that longer lifespans and higher rates of obesity do not fully explain the increase. Some of the systemic and biomechanical factors that can cause osteoarthritis include age, sex, bone density, obesity, muscle weakness, and participation in sports, among others. From the genetic standpoint, common variations that affect many genes, some of which are unidentified, contribute to the risk of developing osteoarthritis. The condition was once believed to be caused primarily by wear and tear damage to the joints over time. However, it is now thought to be mainly the result of the body's failed attempts to repair this damage. In healthy cartilage, there is a balance between buildup and breakdown of the tissue. This balance is lost in osteoarthritis, leading to cartilage damage and, over time, complete breakdown. In response to the bone damage that occurs, the body builds new bone, which leads to overgrowth and reduced mobility in the affected joints. The majority of variations associated with osteoarthritis risk are thought to act by subtly changing the amount, timing, and location of gene activity or expression. The genes whose expression influences osteoarthritis risk are typically involved in the formation and maintenance of bone and cartilage. For example, some of these genes are involved in the development of cartilage. If the genes are not expressed in the right location, at the right time, or in the right amount due to genetic variations, the function of this tissue may be impaired and the risk of developing osteoarthritis may be increased. The genetic changes can also interact with environmental and lifestyle factors that are associated with osteoarthritis risk, such as obesity and activity that places excessive stress on the joints. Arthritis affects a person's overall function and mobility, which can result in activity and other limitations. It is a leading cause of work disability among adults in the United States. The Centers for Disease Control defines arthritis attributable activity limitations as a response of yes to the question, are you now limited in any way in any of your usual activities because of your arthritis or joint symptoms? There are 9 common daily activities that many people with arthritis report are very difficult or they cannot do. The activities are grasp small objects, reach above one's head, sit for about 2 hours, lift or carry as much as 10 pounds, climb a flight of stairs without resting, push or pull a heavy object, walk a quarter of a mile, stand for about 2 hours, and or stoop, bend, or kneel. Based on the analysis of 2013 to 2015 data from the National Health Interview Survey, an estimated 54.4 million, or 22.7% of adults aged 18 years or older, have self-reported doctor-diagnosed arthritis. Of those 54.4 million adults, 23.7 million, or 43.5% of them, have arthritis attributable activity limitation. By the year 2040, an estimated 78.4 million, or 25.9% of the projected total adult population aged 18 years and older will have doctor-diagnosed arthritis. Also, by 2040, an estimated 34.6 million adults, 43.2% of adults with arthritis, or 11.4% of all U.S. adults, will report arthritis attributable activity limitations. These estimates may be conservative as they do not account for the current trends in obesity, which may contribute to future cases of osteoarthritis. The image on the left shows that by the year 2060, the number of citizens over the age of 65 will outnumber the rest of the population. Beginning in 2030, all baby boomers will be older than 65, which will expand the size of the senior population to the extent that 1 in every 5 Americans is projected to be of retirement age. Later that decade, by 2035, the U.S. Census Bureau projects that older adults will outnumber children for the first time in U.S. history. The image on the right displays the projections by the CDC that shows the estimated number of adults diagnosed with arthritis by the year 2040. Again, this is conservative as the projections do not take into account the upward trend of obesity in the United States. The symptoms of OA include hip, knee, and back pain, which leads to a functional limitation and reduction of physical activity. As a result, muscle wasting occurs around the affected joint, and generalized physical deconditioning will also ensue. Studies suggesting an increase in incidence of falls in women but not men with joint pain. In a large general practice registry, only women with hip pain were 3 times more likely to report falls in the past 12 months, whereas there was no increased likelihood of falls in men with hip pain. This is most likely to preserving their pride and or out of embarrassment. Typically, patients with unilateral hip OA develop a Trendelenburg gait. During the stance phase of gait on the affected side, the pelvis is tilted downward on the opposite side to reduce the load on the affected side. The shift of center of gravity to the stance leg therefore no longer occurs, leading to instability. Reduction in joint flexion and extension due to pain, deformity, or muscle weakness may occur as a result of worsening knee OA, leading to increasing deficits in balance control. While evaluating fall prevalence in sufferers of OA is complicated by the large discrepancy between the symptoms of joint pain and radiographic evidence of OA, and the varying disease indicators used by the studies. OA of the hip and knee results in reduced toe clearance, impaired obstacle avoidance, and gait and balance disorders, which may increase risk of falls. Now that we have an understanding of osteoarthritis and how widespread its prevalence is in the senior community, let us explore some of the activities for the lower extremities that can limit muscle wasting and atrophy. A lack of mobility secondary to pain caused by osteoarthritis can lead to muscle wasting, atrophy, and the loss of extensibility of the musculature surrounding the affected joint. The following stretches and strengthening exercises can help prevent contractures by keeping muscles at a natural length, allowing for a more stable gait pattern. Strengthening the muscles that act on the affected joint require movement. That movement increases the temperature of the musculature, which dilates the blood vessels, leading to more nutrients reaching the affected area. The muscles that are listed twice under stretching, hamstring, quadriceps, hip abductors, and adductors, are listed under both the hip and knee as they cross both joints, therefore affecting each joint's mobility. The same can be said for the repeated strengthening exercises for both the hip and knee. Other reasons for exercising affected joints include maintaining bone strength, increased energy, weight control, improved quality of life, and most importantly, improving balance. Keeping the muscle strong is crucial to maintaining support for the bones. A lack of exercise weakens the supporting muscles, which creates more stress on the already affected joints. Along with reducing and reversing muscle atrophy through exercise, the use of manual techniques to the musculature surrounding the affected joints, as well as manipulations and mobilizations of those joints, can be found to reduce pain in osteoarthritis patients. Massage is a mechanical stimulation of the tissues by means of rhythmically applied pressure and stretching. Massage has been used to increase flexibility and coordination, as well as to increase pain threshold, decrease neuromuscular excitability in the muscle being massaged, stimulate circulation, which improves energy transport to the muscle, and to restore joint mobility. The effect of massage on pain is regulated by both the gait control theory and through the release of endogenous opiates. Gait control involves the cutaneous stimulation of large diameter afferent nerve fibers, effectively blocking transmission of pain information carried in small diameter nerve fibers. Stimulation of painful areas in the skin or myofascia can facilitate the release of endorphins and echinephrine, which affect the transmission of pain-associated information in descending spinal tracts. Very light massage, called effleurage, produces an almost instantaneous reaction through transient dilation of lymphatics and small capillaries. Heavier pressure brings about more lasting dilation, which increases blood volume and blood flow, which creates an increase in temperature in the surrounding musculature. If edema is present in the area being massaged, it is suggested that the limb be elevated. The mechanical movements also assist in the removal and hasten the resynthesis of lactic acid. Muscle massage is performed either for mechanical stretching of the intramuscular connective tissue or to relieve pain and or discomfort. It has been shown to increase blood flow to skeletal muscle and thus increase venous return, as well as retard muscle atrophy and increase range of motion. The beginning of each massage is done through a maneuver called effleurage. This technique involves gliding the hands lightly over the skin without moving the deeper muscles. This technique helps increase circulation to the skin surrounding the affected area. Every massage begins and ends with effleurage. Following effleurage, the therapist will move to a technique called petrissage. Petrissage consists of kneading manipulations that press and roll the muscles under the fingers or hands. The muscles are gently squeezed, lifted, and relaxed. The hands may remain stationary or be moved along the length of the muscle. Petrissage helps increase venous and lymphatic return and presses metabolic waste products out of the affected areas through this vigorous action. Petrissage is used to break up adhesions between the skin and underlying tissue, loosen adherent fibrous tissues, and increase circulation to the affected area. In general, the direction of the forces should be applied in the direction of the muscle fibers. Friction massage can be utilized on musculoskeletal structures of ligaments, tendons, and muscle. This technique loosens adherent fibrous tissues and aids in the absorption of local edema. Inflammation around the joints is softened and more readily broken down, so the formation of adhesions is prevented. The primary indications for manual therapy for this presentation include decreasing pain, stimulating circulation, restoring joint mobility, and increasing blood flow, retard muscle atrophy, and increasing range of motion. The contraindications for manual therapy are arteriosclerosis, thrombosis, embolism, severe varicose veins, acute phlebitis, cellulitis, synovitis, abscesses, skin infections, cancers, and acute inflammatory conditions. Mobilizations and manipulations refer to the manual therapy techniques that are used to modulate pain and treat joint impairments that limit range of motion by specifically addressing the altered mechanics of the joint. The mechanical effects of small amplitude distraction or gliding movements of the joint are used to cause synovial fluid motion, which is a vehicle for bringing nutrients to the avascular portions of the articular cartilage. Gentle joint play techniques help maintain nutrient exchange and thus prevent the painful and degenerating effects of stasis when a joint is swollen or painful and cannot move through range of motion. Non-thrust oscillation techniques may be performed using physiological motions or joint play techniques. Grade 1 joint manipulations are small amplitude, rapid, rhythmic oscillations performed at the beginning of the range and primarily used for treating joint limitations due to pain. Grade 2 are large amplitude rhythmic oscillations performed within the range, not reaching the range limit. Similar to grade 1 oscillations, they are used for joint limitations due to pain. Grade 3 are large amplitude rhythmic oscillations performed up to the limit of the available motion and are stressed into tissue resistance. This technique is used for tissue extensibility. Grade 4 are small amplitude, rapid, rhythmic oscillations performed at the limit of the available motion and stressed into tissue resistance. Similar to grade 3, this technique is used for tissue extensibility. Non-thrust sustained joint play techniques are performed to distract or translate the joint surfaces. The rate of application is slow and sustained for several minutes, followed by partial relaxation, and then repeated depending on the indications. Grade 1, or small amplitude distraction, is applied when no stress is placed on the joint capsule. It equalizes cohesive forces, muscle tension, and atmospheric pressure acting on the joint. Intermittent distraction is applied for 7 to 10 seconds, with a few seconds of rest between for several cycles. Grade 2, provides enough distraction or glide applied to tighten the tissues around the joint. This grade is primarily used for the initial treatment to determine sensitivity of the joint. If applied intermittently, it can also be used to inhibit pain. Grade 3, a distraction or glide applied to with an amplitude large enough to place stretch on the joint capsule and periarticular structures. This grade is performed by a minimum of a 6-second stretch force, followed by a partial release, to the range of grade 1 or 2, then repeated with slow, intermittent stretches at 3 to 4-second intervals. Exercise, movement, and manual therapy are all fantastic options when treating a patient with osteoarthritis. Exploring the idea of using these techniques alone or together is what we will now delve into. This case series, titled Clinical Outcomes Following Manual Physical Therapy and Exercise for Hip Osteoarthritis, describes the outcome of individual patients with hip OA treated with manual physical therapy and exercise. 7 patients referred to physical therapy with hip osteoarthritis and/or hip pain were included in this case series. This is a small study with only 7 participants, but is included in this project as it describes, in detail, the joint mobilizations performed. All patients were treated with manual physical therapy followed by exercises to maximize strength and range of motion. 6 of 7 patients completed a Harris Hip score at initial examination and discharge from physical therapy, and 1 patient completed a global rating of change scale at discharge. 3 males and 4 females with a median age of 62 years and median duration of symptoms of at least 9 months participated in this case series. The median number of physical therapy sessions attended was 5. The median increase in total passive range of motion of the hip was 82 degrees. The median improvement on the Harris Hip score was 25 points. The single patient who completed the global rating of change scale at discharge reported being a great deal better. Numeric pain rating scores decreased by a mean of 5 points on a 0 to 10 point scale. All patients exhibited reductions in pain and increases in passive range of motion, as well as a clinically meaningful improvement in function. Despite the small sample size of this case series, I would accept their results as valid and agree that more study is required to determine if manual therapy, when used with exercise, decreases pain levels in patients with osteoarthritis. A long axis non-thrust mobilization of the hip. The patient is placed in supine with contralateral limb flat and slightly abducted at the hip. Gentle and progressive long axis distraction oscillations were performed by the therapist with a 2-handed hold at the malleoli. Oscillations were grade 2 or grade 3 with a progressive increase in intensity. A 2-therapist caudal hip non-thrust mobilization with combined medial and inferior glide. A 2-person side-lying medial non-thrust mobilization combined with distraction was utilized. Distraction force was first applied, then a medial and inferior translation of the femoral head was provided by the second therapist. The technique was most often an oscillatory glide at the middle to end of range of osteokinematic motion, with the end range being the passive limit of available hip motion. The anterior hip non-thrust mobilization. Prone anterior glide of the femoral head. The knee was placed off the table to allow for the technique to be completed where there was a restriction and abduction of the involved hip. This was also used in conjunction with the patient actively contracting the external rotators of the hip to allow increased anterior glide of the femur. The patient actively pushes the knee into the therapist's hand, facilitating a contraction as the therapist mobilizes the femur anteriorly. This research, despite the limited number of subjects, showed very positive outcomes for patients diagnosed with osteoarthritis. The next article is a randomized control trial that shows the effectiveness of the techniques of this project on the knee. This randomized control trial, titled Effectiveness of manual physical therapy and exercise in osteoarthritis of the knee was performed to evaluate the effectiveness of physical therapy for osteoarthritis of the knee, applied by experienced physical therapists with formal training in manual therapy. 83 patients with osteoarthritis of the knee were randomly assigned to receive treatment into a treatment group consisting of 42 participants or a placebo group consisting of 41 participants. The treatment group received manual therapy applied to the knee as well as to the lumbar spine, hip, and ankle as required, and performed a standardized knee exercise program in the clinic and at home. The placebo group had subtherapeutic ultrasound to the knee at an intensity of 0.1 watt per centimeter square with a 10% pulse mode. Both groups were treated at the clinic twice weekly for 4 weeks. Distance walked in 6 minutes, and the sum of the function, pain, and stiffness subscores of the Western Ontario and McMaster University's Osteoarthritis Index were used to analyze the data. A tester who was blinded to the group assignment made group comparisons at the initial visit before initiation of treatment at 4 weeks, 8 weeks, and 1 year. Clinically and statistically significant improvements in 6-minute walk distance and WOMAC score at 4 weeks and 8 weeks were seen in the treatment group, but not the placebo group. By 8 weeks, average 6-minute walk distances had improved by 13.1%, and WOMAC scores had improved by 55.8% over baseline values in the treatment group. At 1 year, patients in the treatment group had clinically and statistically significant gains over baseline WOMAC scores and walking distance. The researchers concluded that a combination of manual physical therapy and supervised exercise yields functional benefits for patients with osteoarthritis of the knee and may delay or prevent the need for surgical intervention. The analysis of the statistical data were independently analyzed and is well described and very thorough. Sample size of participants who finished the study was 69, and based on how the information pertaining to the study was handled, I would state that this study is valid. The stretches and range of motion exercises performed by the treatment group in this study are as follows: a standing calf stretch, a supine hamstring stretch, and a prone quadriceps stretch were all undertaken by the participants. Each stretch was performed 3 times for 30 seconds each. Following stretches, the participants performed range of motion exercises consisting of riding a stationary bike for 5 minutes, a long sitting knee flexion exercise, and a long sitting knee extension exercise, which were both performed twice for 30 seconds with a 3-second hold at end range. The strengthening exercises for the treatment group consisted of a static quad set and full knee extension and consisted of 1 set of 10 repetitions with a 6-second hold with 10 seconds of rest between repetitions. They also performed several closed chain progression exercises, standing terminal knee extension, and seated leg press for 30 consecutive seconds. As the patient progressed, the resistance was increased as they were able to tolerate. Patients also performed 30 consecutive seconds of step-ups, with the step height being increased as tolerated. Manual therapy applied to the knee, hip, ankle, and lumbar spine consisted of passive physiologic and accessory joint movements, muscle stretching, and soft tissue mobilizations applied primarily to the knee. If the patient displayed limited active or passive range of motion in the hip, ankle, or lumbar spine, or if those areas contributed to overall joint dysfunction, manual therapy was applied to those locations as well. The previous 2 articles have shown that the combination of exercise and manual therapy provided improved pain levels, range of motion, and mobility. However, is it the exercise or the manual physical therapy that is providing the most benefit for the patients diagnosed with osteoarthritis? The following trial compares the 2 options to make that determination. This single-blind, randomized control trial titled Comparison of Manual Therapy and Exercise Therapy in Osteoarthritis of the Hip was performed to determine the effectiveness of a manual therapy program compared with an exercise program in patients with osteoarthritis of the hip. Of 109 patients included in the study, 56 were allocated to manual therapy and 53 to exercise therapy. No major differences were found on baseline characteristics between groups. The manual therapy program focused on specific manipulations and mobilizations of the hip joint. The exercise therapy program focused on active exercises to improve muscle function and joint motion. Success rates and the primary outcome after 5 weeks were 81% in the manual therapy group and 50% in the exercise group. Furthermore, patients in the manual therapy group had significantly better outcomes on pain, stiffness, hip function, and range of motion. Effects of manual therapy on the improvement of hip pain, hip function, and range of motion endured after 20. Damn it. The duration of a session for the treatment group was 25 minutes. The frequency was twice a week for a total of 9 treatments. Each session started with stretching of shortened muscles in the following muscle groups: iliopsoas, quadriceps femoris, tensor fasciae latae, sartorius, adductors, and gracilis. The starting position of the patient was supine. The patient has to experience a stretching sensation, and actual stretching is applied for 8 to 10 seconds. Repeat stretching of each muscle group 2 times for a total time of 10 to 15 minutes. The therapist's hands are placed just above the ankle joint. All manipulations are performed in slight abduction to avoid slamming of the femoral head into the acetabular surface. The first traction manipulation is performed in a maximum loose packed position of the hip joint. With each following manipulation, the hip joint is placed in a more limited position, which differs per patient. In total, a maximum of 5 manipulations can be applied. The final manipulation is performed in the most limited position of the hip joint. In between manipulations, active assisted motions of the hip joint are performed for relaxation. To evaluate the success of the manipulation, after each manipulation, end feel of the hip joint is tested using a traction test and by passive hip flexion. This is compared with the contralateral hip. When the end feel of the treated hip is similar to that of the contralateral hip, optimal result is concluded. The duration of a session for the exercise group was 25 minutes. The frequency was twice a week for a total of 9 treatments. The exercise program was tailored to the individual patient's needs by the therapist. The first session is used to compile exercise therapy treatment goals by questioning, physical examination, and observation of walking ability. It is of great importance to identify specific impairments and disabilities that are of high priority to the patient. There are 4 main treatment goals on which exercise therapy focuses. 1. Increase of muscle function, including endurance, strength, and coordination. 2. Improvement of range of motion. 3. Decrease of pain. And 4. Improvement of walking ability. Furthermore, education and advice needed to be provided to the patient. Muscle function. Mainly active exercises have to be applied to improve muscle function. Exercises consist of muscle strengthening exercises with the use of weight or strengthening equipment. Endurance is trained by walking on a treadmill or cycling on a home trainer. Finally, coordination is trained through walking exercises with increased complexity and through balancing exercises. Range of motion. If regarded necessary, range of joint motion can be increased through both passive and active exercises. Active exercises should have the upper hand, however. These exercises consist of 3-dimensional motions of the hip joint that go beyond the range of joint motion that most patients use in activities of daily living. These exercises can be performed in weight-bearing and non-weight-bearing positions. In addition, these exercises can be applied in different positions, such as during standing, sitting on a chair, and while lying down. Pain. If regarded necessary, exercises for pain relief can be applied. Pain relief is also achieved through active joint motion exercises and through stretching exercises. In addition, second and third degree traction in the maximum loose pack position of the hip can be applied. Walking ability is trained by specific walking exercises with adjustment of gait pattern, use of walking aids, and instruction on climbing of stairs. This capstone project provides very strong evidence that the use of manual therapy with or without the combined use of exercise therapy can provide a decrease in pain levels while increasing the patient's range of motion and ability to perform ADLs. Specific types of manual therapy that include massage, muscle stretching, joint mobilizations, and manipulations to the area of the affected joint have been proven to provide the patient with an overall improved quality of life. These results show that despite the benefit of exercise to aid with pain relief in elderly patients diagnosed with osteoarthritis, it is the proper applied use of manual physical therapy that provides the most comfort and aid. So the next time you visit your sweet little old arthritic grandmother, maybe suggest that she consider some exercise and manual physical therapy. Perhaps you'll be able to join her and her friends at their next canasta party. First of all, thank you for taking the time to view and listen to this capstone project. Unfortunately, the state of the world right now prevented me from presenting this to you in person and allowing me to answer your questions face to face. If you have any questions following viewing this presentation, please reply to the email that was contained in the link for this project. As this is my final project, please take a moment to fill out the evaluation form that I included and send back to me as soon as possible. And thanks again for listening and watching. I appreciate it, and I appreciate you guys. Thank you.